everybody. My name is Garrett Smith, and I am the CEO and Managing Editor of VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar. This one is hosted by HDAI, which is the Health Data Analytics Institute. I'm very excited about today's presentation, and it's called How Houston Methodist ACO is Cracking the Code on HCCs. And I got a little preview of this presentation before, and I think there's a lot of great information that's going to be shared today. But before we jump in, a few items of note, just some housekeeping things that I wanted to go over before we start. First of all, everyone has joined today in listen-only mode, so we can't hear you or see you, so you don't need to worry about turning your microphone off or your camera off. But we are going to have a time for some Q&A towards the end. So if you have a question at any point during the presentation for any of our speakers, go ahead and drop that into your control module. There's a place specifically for questions. We're going to get to as many as we can. We do have a good audience today. So if we don't get to yours, don't worry. Someone will reach out afterwards to make sure that your question gets answered. So even if we're wrapping up at the end, go ahead and drop your question in. Also, the session today is being recorded, and so when we conclude, maybe about an hour or so after we're done, you will receive an email, and in that email, there will be a link to today's recording as well as to the slides for download, and that way you can bring those down and review those, share them with colleagues and friends, and we hope that you do. And there's a lot of material to cover, so I'm sure you'll want to pull that down for your reference. Finally, let's see, I think we've covered all of our housekeeping items. So without further ado, let me very briefly introduce our speakers today. With us, we have Ms. Wajiha Waheed, and she is the Director of Finance and Operations at Houston Methodist Coordinated Care ACO. We also have Mahima Malakapuri, and he is the Senior Data Scientist at HDAI. And we have Ms. Emily Hightower, she is the Manager of Population Health also at HDAI. They will be our guides for today. And Emily, I believe you're going to kick us off, so I will hand it over to you at this time. Welcome.
Okay, thank you so much, Garrett. So thank you, everyone who is here with us today. We're incredibly excited to be here for this webinar, and I want to start by just sharing a little bit about who Health Data Analytics Institute is and what our Health Vision platform does. So we are a 70-employee predictive analytics company based in Boston. A bit about our client base, you can see here on this slide, we partner with both health systems as well as ACOs. Some are Houston Methodist, Cleveland Clinic, Dana-Farber, and many other value-based care organizations across the country. For our health system clients, we actually have an EHR embedded platform that incorporates available, structured, and unstructured EHR data, claims, and other sources of data as well. We have a privileged access to all Medicare claims since 1999, and this enables us to do a lot of advanced predictive and analytics work and implement into clinical workflows. So to talk a bit more about that platform and that privileged access, what it enables us to do, the CMS database updates monthly. We are grandfathered in, so we will continue to be able to use this database for our digital twinning and our large predictive models. We have 140 million patients that we can access, 500 plus billion encounters. And as I previously mentioned, it goes back all the way to 1999. So that's 25 years of longitudinal records. We have our own unique digital twinning. This methodology allows us to deliver highly valuable, actionable precision insights. And all of our models, there's hundreds, they are published, peer-reviewed methodology. They're transparent and explainable, and they have enabled us to do some of this amazing work that we're going to be talking about today. We've partnered with Houston Methodist Coordinated Care ACO on HCCs very intentionally over the last year, and specifically in the last 4 to 5 months. And we've been doing population health initiatives with them since 2022. And it's been an amazing partnership, and we're very eager to share more with you today about HCC recapture and how we've tackled that together. So we'll first talk through HDAI's strategy for high impact HCC recapture, and then we'll turn over to talk more about specifically at HMCC, what we have done to accelerate that recapture. As Garrett mentioned, we'll have time at the end for some Q&A, and please continue to put comments in so that we can get to those at the end, or as Garrett mentioned, so that we can come back and reach out after the webinar ends. I am going to let Wajiha share a bit more about HMCC and the amazing work they're doing before we dive into the actual data.
Thank you, Emily.
Of course.
Great. Hi, everyone. For those of you who have not heard of Houston Methodist Coordinated Care, we are an accountable care organization participating in the CMS Medicare Shared Savings Program on enhanced track, taking two-sided risk. We were formed in 2017, and this is our 9th year of operations. In terms of our ACO structure, we are a primary care-based model with 2/3 employed physicians and 1/3 private and aligned physicians. So for this year, here are some 2025 stats, just so an overview. So for this year, we're assigned about 54,000 MSSP patient lives and are the largest MSSP ACO in the city of Houston. We are a high-performing primary care ACO network with 300+ primary care clinicians in our program across 90 clinic locations. We take pride in our patient-centered approach with wraparound services for their continuity of care with their PCPs, ACO case managers, ACO dedicated nurses, and ACO pharmacists. And based on the performance year 2024 final results, our ACO ranked number 2 in quality performance nationally among the 10 largest health system MSSP ACOs. And also, we're very proud of being ranked number 1 nationally for generating the highest average savings per patient among the same cohort, leading to a milestone earned shared savings of $50.4 million. Next slide. Great. And I will now provide you insights on our ACO strategy of supporting our physicians, our clinicians in HCC documentation, coding, and risk adjustments. So overall, we have 3 main strategies. So let's look at number 1. We provide patient assessment tools and resources. So this is our current state. We are very consistent in providing our physicians visibility into HCC coding at the patient level, physician level, and also performance at the practice level. Majority of our practices are on Epic, and in current state, our Epic practices are utilizing the Epic HCC BPA, which is the best practice advisory tool, which pops up at the point of encounter to address the open conditions. Now, I also mentioned that 1/3 of our practices are private aligned. So to accommodate our private physicians, we actually have a very unique strategy. We provide them with their patients' risk adjustment forms that are formulated through CMS claims data and list the suspected conditions that were billed for in previous year for each and every MSSP patient as a coding guide to these physicians. We distribute these paper forms 3 times a year as claims progresses. Now, again, as I mentioned, we have Epic as well as over 10 different EHRs that we're working with. Number 2, we utilize data analytics and population health support platforms to monitor performance. So we collaborate with external analytical partners such as HDAI to aggregate and analyze patients and claims data. So this is what gives us the visibility to target patients whose chronic conditions may not be fully captured in the record, so enabling the ACO to really prioritize outreach, follow-up, and chart reviews. We routinely do these extensive reviews on a monthly basis to capture and continuously improve risk adjustment gaps and drive accuracy. So number 3, we are laser focused on providing practice, physician level support in workflows and education. We are able to achieve strong physician engagement with monthly in-person meetings with the entire group of physicians and consistently reporting out their performance. Our ACO invests heavily to support the physicians with the clinical infrastructures and resources as an extension of their practices, which really reduces the burden on the physicians and drives stronger care coordination for the patients, leading to improved outcomes. So ultimately, Houston Methodist Coordinated Care ACO is really driven to ensure that every patient risk is accurately documented for the ACO to deliver the highest quality, best coordinated, and financially sustainable care.
Thank you, Wajiha. And that's a great segue because we're going to dive into really HDAI's strategy for high impact HCC capture. But I think we all know that education piece that you were talking about at the end is really the fundamental basics. So most of us who are here at this webinar today probably are familiar with the basics of risk adjustment and HCCs, but to just level set, hierarchical condition categories, otherwise known as HCCs, primarily drive that total risk adjustment factor or RAF score. Usually you're going to see that about 60 to 70% of that RAF score is driven by the HCC itself. And then the other 30 to 40% is typically coming from demographic status. So the HCCs have 7,770 ICD-10 diagnosis codes that map to 115 different clinical categories. And this is true for version 28, which we are in this year, which is a change from version 24 last year, as most of you may know. Each HCC has a weight, which is effectively a coefficient in that RAF calculation, which we're showing across the bottom. For demographic status, we have enrollment category and institutional status. So are you community dwelling? Are you institutionalized? We use these to build the total RAF score. HCCs, it's important to keep in mind, are what we can impact at that ACO level with the proper documentation and coding, whereas you're always going to have that about 30 to 40% that is a fixed factor. We can't change it. So looking at this example, thinking about we have, maybe lung cancer, seizure, mild dementia, and supraventricular tachycardia. That is 68% when you look at those coefficients. And then you have your age, not Medicare eligible, community-based, and that's 0.6. So that's your demographic status. And all of that totals up to be the 1.87 RAF score that you're seeing there. So it's just helpful to kind of level set with this as we dive into how HDAI really utilizes this information to use a unique way of tackling this problem. So I'm going to turn it to Hima. He's our senior data scientist, as Garrett mentioned at the beginning, and he has really done a ton of work at our company on building out the analytics, working with Wajiha to really create a tool that can best serve HMCC as well as other organizations. So Hima, I'm going to turn it over to you.
Oh, thank you, Emily, for establishing the importance of HCCs for determining RAF. Let's look at few real-world examples where HCCs haven't been documented. And this data has been recently pulled from an ACO partner's patient pool as recent as 3 days ago. So these are 3 real examples, of course, de-identified patients. The first example is a 72-year-old male with HIV who's been consistently documented for the past 3 years, 2022, 2023, 2024, but the ACO missed documenting his condition in 2025. We've confirmed that this patient has been actively managed year to date. And in fact, they're on antiretroviral medication as well. So there's no question that this patient is being managed, but the documentation has been missed. The second case is a 65-year-old female with cystic fibrosis. Again, we are looking at patients who had consistent history of documentation, so that we were ensuring this is not um, an outlier and this is an actual missed opportunity. And we didn't see a documentation in 2025 in the claims database. And we have an 8-year-old male with end-stage heart failure who's currently on diuretics and beta blockers. Again, with a consistent capture history, we didn't see any documentation in 2025 as of yet. And as you can see, there's a huge RAF opportunity that the ACO is missing just from these 3 patients, 0.75, 0.87, 0.40, when translated into financial incentives. That's a huge opportunity that is lost. And we're talking about patients who are being managed and who are actively being cared for. We believe ACOs and providers should be compensated for the care that they're providing. And HDAI is all for patient welfare, and also ACOs having a deep insight into their HCC opportunities and getting their shared savings for the care they're providing. Could you please move on to the next slide, Emily?
Did it advance for you?
It did now. Thank you.
Okay.
Well, we've seen that even with a strong history of care, persistent chronic conditions often go uncaptured. And national data shows that recapture rates for major conditions like heart transplant, HIV, Parkinson's, dialysis, cystic fibrosis, end-stage heart failure frequently fall short of 100% capture, even among patients with a strong history of documentation. I would like to say that it's important to approach this with empathy and realism because providers are working in complex environments and it's simply not practical or necessary to expect every single HCC to be captured every year. So we are not expecting ACOs to reach 100% documentation on every HCCs, or in fact, every year. The real value is not in finding HCCs with big apps either. Other services do that as long as you have access to claims, and CMS has the software publicly available, so you can understand broadly which HCCs are high RAF impact HCCs. What we believe is instead of just taking the raw RAF opportunity or the gaps, combining those gaps with each patient's clinical history and national expected recapture rates that we have access to due to our privileged access to Medicare data can help boost ACOs approach their HCCs much effectively. This is exactly where HDAI's approach stands out. We help ACOs twin their patients and HCCs to national expected capture rates. And this empowers the care teams to focus their efforts where they matter the most, like supporting clinicians and ensuring the patients and the conditions with the greatest needs are recognized and cared for. Oh, thank you for moving on to the next slide, Emily. I know this slide looks a little dense. I won't go through everything here. This is a snapshot of our HCC capture product. We wanted to share this with you because we're really excited about how this product is enabling our ACOs to focus on their HCCs. Let's walk through this quickly. What we have here is a sample patient. In fact, it is an actual patient who has been de-identified. And this snapshot, I believe, Emily, we took from last week's recent refresh.
That's right.
Yeah. Let's see.
And I think it just emphasizes what you were talking about on the prior slide about how we use that weighted gap with that historical annual capture.
Exactly. I mean, this patient I see had an annual wellness visit on May 15th, 2025. And there are about 4 HCCs that have not been captured yet. and 2 of them, which we flag as forever HCCs or chronic conditions, have not been captured yet. And the annual capture history section to the left showcases again what the capture history has been for the past 3 years. So in 2022, almost all the conditions have been captured, 2023 too, and this patient was not documented properly in 2025 and 2024 and 2025 year to date. So you can think of this as a snapshot of the patient status and HCC capture. Where HDAI comes in is with its annual and year-to-date recapture rates predictions, and combining that with the gap and coming up with a weighted gap. So the first column that you see, annual recapture rate. So let's look at the highlighted example for heart failure. So 54.2% is HDAI's estimated recapture rate based on national trends for a patient for HCCs that belong to for the heart failure HCC with a history of capture in 2023, 2024, and no history in 2024. And 46.6 represents the year-to-date recapture rate. We provide annual and weekly year-to-date recapture rates, so you can assess from the beginning of the year what is the national recapture rate for a particular HCC. So providers are not alarmed with the full gap at the beginning of the year. We expect the year-to-date recapture rate to be in 5% or 10% the first few months, and then it climbs up and then it flattens out at the annual recapture rate. By multiplying the annual recapture rate or the year-to-date recapture rate with the actual RAF opportunity, we come up with the weighted gap, which is essentially HDAI's adjusted risk opportunity that we believe ACO should focus on instead of focusing on the raw RAF. So that's the last column to the right. So the weighted gap column to the right. Just to drive this home, I know there's a little bit of math here, but I believe it's really important to understand the essence of weighted gap because it has really helped our partners focus on the opportunity that is most clinically relevant and the highest impact. So if you take the example of heart failure again, the RAF opportunity, the raw RAF opportunity is 0.36. Once you multiply it by 47%, which is the year-to-date expected recapture rate, you end up with a weighted gap of 0.17. If you do the same for chronic ulcer, it's about 0.13. So if we surface the HCCs for this patient, when we're reviewing this patient with an ACO, we would surface heart failure above chronic ulcers for skin, despite the huge opportunity that chronic ulcer for skin shows when we look at the raw RAF, because we believe it's more clinically relevant and it's more likely to be captured, and this patient is more likely to have that condition persist. So that's in essence the science behind the weighted gap. Could you please go to the next slide, Emily?
Yes.
Okay. Let me set the stage for how HDAI approaches HCC capture when looking at different coding patterns for a patient. And as I talk through the coding patterns, I would like everyone to focus on the table to the left. You'll see a series of patterns made up of ones and zeros. 1 means the diagnosis was captured, that is coded for the patient in that particular year, and 0 means it was not captured in that year. So if you see a pattern like 111, it means that heart failure, which is what we are looking at in this particular site, has been coded for that patient for 3 consecutive years consistently, 2022, 2023, and 2024. And if we look at, say, 001, that would mean it wasn't captured in 2022, 2023, and it was captured in 2024. And 100 is an example that we want to highlight here. Depicts that this condition was captured in 2022, not in 2023, not in 2024. That's the one in orange. So I'll give you a few seconds to orient yourself with the table before I move ahead. Okay, so moving on to the average recapture rate for each of these patient pools, you'll notice that in September, if you look at a patient pool with a consistent capture history of 111, we expect the average recapture rate for the nation to be 88%. Now, for the same HCC, for a patient pool with recapture history of 100, we expect the average recapture rate to be 23%. So at HDAI, we are very sensitive to a patient's history. We believe it tells us a lot about the clinical relevance of that code and the likelihood of that code being captured. And we want to assist clinicians and embed this recapture likelihood in our weighted gap, which, as I described before, is a key concept that we are driving in our reports. So moving on to the chart, this is a translation of the numbers that we are seeing to the left. It's a snapshot of September. But if you look at the recapture rate progression over time, you can see even for a patient pool who has a history, which has a history of 111, it doesn't make sense to alarm the providers at the beginning of the year with the full weight. Providers capture the codes at a rate that improves over time, and it flattens out at 0.87 or 0.88. So our predictive models give you an insight based on the current time of the year that we are in, so you can get the appropriate weight for the period that you're looking at and for the patient pool that you're concerned about and for the HCC that you're looking at. So that's about 52 weeks and 115 HCCs and 8 different combinations of coding patterns that we look into. That amounts to about 48,000 predictions. So our predictions are dynamic, and the weighted gap keeps refreshing every week so that you get timely, relevant updates so the physicians can focus on the conditions that they really need to review depending on the period that we are in. Could you please move to the next slide, Emily?
Yes, here you go. Just another example, right?
Yeah, this is just another example. We're looking at diabetes without complications. Just to drive home that we build these models for each HCC, and interestingly, the ones that are more clinically relevant obviously are the ones that have been captured regularly. And a condition like diabetes has a higher average recapture rate, so the weighted gap is also higher for diabetes. So if you have anything else that's perhaps the higher weight, diabetes would be surfaced with more emphasis because of the average recapture rate being higher. And it also happens to have a higher weight in general. So this is just another example. Okay, I won't take too much time. Let's tie this up here. Okay, yeah, so that's it with our under the hood calculation for weighted gap and why it is very important to look at HCCs, not just as raw RAF weights that we should go after. The multiple services that can provide that, but it's very important to look at the patient's history, look at the average recapture rate, and really update our predictions every week. And that way we can provide our ACO partners with the most relevant information that they can use when they go to their physician. So with that, I'll hand it over to you, Emily.
Perfect. Thank you. So knowing we just looked at a lot of data, we do want to bring this back to sort of your real world and then really dive into how Wajiha kind of spearheaded the effort at HMCC to utilize all of that data and review it with us monthly and sometimes even weekly and put it to action. But quickly, I'm not going to cover every single point on this slide because I know everyone is probably very eager to hear from Wajiha. But just to cover a few about how HDAI really solves for this HCC recapture problem that we're seeing all across the nation. We have our challenges with the existing implementations, and then we have really the solution that HDAI uses for that specific challenge. So first and foremost, we know providers can be asked to capture every possible code for every patient. It's overwhelming. There can be alert fatigue if those BPAs are continually popping up, and it can just be an inefficient use of time. So through what Hema just explained, we surface clinically appropriate, high impact HCCs, and we guide this with our expected recapture predictions from national twins, really helping you focus on what we believe has the highest impact. Additionally, there's many alternatives where you look at the physician note level without identifying physicians or groups that really need that particular support. Our product solves for that. What you were looking at in the product was patient level, and then we continue to back out from there and we can go all the way up to the ACO level. Additionally, an area where HDAI really provides a solution is that usually there's not a great mechanism to really understand where you're tracking mid-year. And the way we do this is because of that access that we have, we can continually monitor our ACO partners' progress against how they're doing against their peers. So every week or every month we're meeting to review a national trend line. And additionally, we normalize these RAF scores every month. It gives you a real sense of where you stand relative to the nation, because this is important, knowing that it's not just enough to recapture better than your own ACO did in the year prior, but really you have to look to the nation and potentially even the top 10% of the nation to get where you want to be. Furthermore, we already solve for what can be complicated. So like this year, many probably encountered the switch from V24 to V28. We give this stable version agnostic structure that really just simplifies the implementation and education. And I think Wajiha will be able to speak to that a bit more. But we just try to make it as consistent and as easy as possible so that we kind of do that back end work and then allow the boots on the ground to do the rest. We know that change management is hard. We know that with HCC coming off as a financially driven incentive, it can be hard to get buy-in, but we also know that HCC recapture allows you to take the best care of your patients based on what their true clinical needs are and get compensated fairly to deliver that care. So I'm very excited to let Wajiha talk about our initiative over the last year with HCC, and I'll hand it, Wajiha, I will actually talk a little bit about this first and then I'll hand it over to you. This graph right here, I just want to orient you quickly to the way we think about percentile. Because there has been a massive improvement at HMCC just in the last 4 months. First percentile is best. That's what we're striving for. 100th percentile is worst. So that's why you're seeing the graph go in a downward trend. However, that downward trend is amazing news for HMCC. We've seen an 11 percentile rank improvement, and it's all a credit to taking that data and putting it to action. So now I will hand it to you to talk about how you've done that.
Great, thank you, Emily. Okay, so here is our 2025 risk adjustment. Overall, there's a drop in our risk adjustment trend. But before we talk about the drop, I want to kind of draw your attention to our 5-year full year trend from 2020 to 2024. So our ACO, for 2020, 2021, and even like 2022, where we're really on a good track. Each year, our goal is to reach that 3% cap. And so, we have a set of resources, tools that we're going to talk about in a second. But as you could see, when we went to 2023, we were worried that our risk adjustment is actually aggregate scores are dropping. And so we put in a number of efforts that actually supported our physicians in terms of doing patient chart audits, education, setting up a risk adjustment documentation course to really level set their understanding of the HCC coding, the meet criteria, so on and so forth. And hence, in 2024, we saw that improvement in our RAF scores, and then we were at 1.10, slightly below our cap for the 2024 performance year. But again, 2024 performance year was a great year for us overall, as our physicians really honed into the coding and documentation. So now, really looking at what's the story for 2025. So yes, this is correct. Our trend is looked downward as we looked at it, but basically what's going on is that our ACO renewed in a 5-year contract in the MSSP program, and contractually we are being rebased based on this year's performance. Because it's been a while, we didn't really understand the impact, but it really hit us hard when we received our Q1 2025 risk adjustment performance mid-year, and we were really concerned because our RAF score was actually 1.07, dropping below our benchmark of 1.09. So clearly we had to act fast, and we had to get in front of this negative trend, and that we had to develop an intentional interventional strategy to really avoid the financial impact, as I would draw your attention to those numbers, indicating that 1% increase in the risk adjustment factor score drives 6.8 million in shared savings. But on the other hand, 1% decrease can lead towards a loss of 4.6 million. So we had to act. And so before I talk about what we did in 2025 differently, I do want to, give you insights into our existing tools and resources. I really talked about our EPIC BPA tool that all of our EPIC practices are utilizing. I spoke about our annual risk adjustment patient assessment forms that we take out to our private practices 3 times a year as claims are progressing. In addition, each year our ACO actually curates a risk adjustment and HCC pocket coding booklet to give physicians support, a quick guide into all of the HCC codes by specialty. Also, every year we bring out a risk adjustment coding, kind of like a cheat sheet card for the most missed codes that as we audit through the year and based on our true findings of our ACO performance. I also talked about in 2023, we introduced working with HC Pro, we actually curated a very customized course for our ACO, which is now a standard requirement for every new clinician who joins our ACO has to take the course every year. And so it's really free of charge, and it's on an open platform that they can easily access. So all that was already there. But of course, as we looked at our trend, we have to do more because we're in our rebase year. So as Emily alluded to earlier, HMCC has been partnered with HDAI. Since last year, we had access to their Health Vision platform with the predictive analytics and AI platform that actually we knew, but we weren't really utilizing, to be honest. So, we went back to this platform and we did a brainstorming session with HDI, Emily, Hima, and team. And, as they're reporting out our performance monthly, clearly we were concerned. And so we started really evaluating the HDI Health Vision platform. And then, we really saw how beneficial and beautifully designed in terms of easy to use and clearly laid out the platform was. And so that led to a number of efforts from the ACO. We actually brought that platform in terms of the physician level reports that listed as the snapshot report that Hima went over. So we actually brought that in platform view to our board, and pretty much all of our board is our primary care physicians, and got feedback. And so everyone felt like this was a really strong tool. So we partnered up with HDI and we said, how can we convert this platform into an actionable report? What can we do so we can actually take this report to each and every one of our physicians, and they can utilize this to understand where are those gaps in coding and documentation? Because the difference being, this is not in the EHR. This is claims data that has been billed and now being analyzed with a 3-year look back to clearly see, oh yes, these are the chronic forever conditions that the clinician actually didn't address at the time of that annual wellness visit or a sick visit that they had an opportunity for. And so we will talk more about that. But in addition, some of the other initiatives that our ACO, actually honed into was doing a patient chart coding review across our physicians whose RAF scores were less than 1.00, because clearly we felt there was opportunity. And so we did one-on-one educational sessions with our physicians. But in addition, we also partnered with the Houston Methodist revenue cycle leader in kind of also approaching it at the claims level review, and to see, and again, this was a selected group of physicians whose RAF scores were below 1.00 based on our Q1 performance. So we were tackling this issue in all of these different directions. But now on the next screen, Emily, if you can go, I can talk about what we did and what it looks like. So yes, we had to get the buy-in and we had to act, right? And so this was, again, a new ask, a new report that we're bringing to our physicians. And of course, there's always, over information, there's fatigue. Physicians are just constantly bombarded. But we had to jump in and really take this out to our physicians as an opportunity to see how they're going to respond to this. We have another slide that really blows up what this actual report looks like, but in a nutshell, we brought out this HCC recapture opportunity report, which was custom designed by HDI based on the feedback from our board members, and then we rolled it out, putting this report in the hands of every single physician starting August. And so as we have our scheduled monthly meetings with our physicians, we started educating our physicians about the report, and we'll go over an example so you get a better understanding of it. But overall, we have been consistently doing that for 3 months now, and we saw a big improvement, which also Emily kind of shared how we moved the needle in a very small span of time. And so in the next slide, we will kind of look deeper into what this report means. But again, educating our physicians, giving them the tools and resources, and monitoring it's what's moving the needle. And so as we reported on our last set of reports that was looking at all of our claims data at the end of October, our overall, we saw a 28% reduction in RAF opportunities, meaning our physicians actually were utilizing these reports and were agreeing with those gaps as they were highlighted, and they weren't billed for 2025. And as you could see, we started with gaps of like over 10,000 patients to dropping it down to like 7,854. But because we only started this effort in August of this year, as we went through, our monthly report out on the same report, we're now already in October, but we're so close to the end of the year. So we have to quickly strategize and focus on where we have the biggest impact. Hence, what we started reporting from our last report, we started educating our physicians that we are now going to only target our highly risk patients who has RAF gap of 0.50 or higher, and again, having that very strategic approach, considering few weeks, really, not even, we don't have months remaining for the end of the year. We saw a drastic improvement focusing on those sickest patients for our ACO. And so thank you, Emily, for pulling up this amazing HCC recapture opportunity report that we have been now consistently taking out to our physicians. And again, when we say every single month, the way the report works is that as the physician captures the code at the point of the visit, and that happened, let's say in August, in September, that patient, if all the conditions are captured, that patient is going to fall off from this list. So this list really empowering the physicians, because every month as we take the list out, it's getting smaller and smaller, right? And on the other side, the RAF scores are getting appropriately captured, because this is exactly what we want for each and every physician's applicable conditions to be captured and coded within the year. So as you could see, the display of this report, it's so easy. And what we did is we really sorted by highest RAF opportunity, meaning this is your sickest patients. And we also let them know what are the risk segment of that particular patient, and we kind of give them a guide as to what it is that we want to accomplish from this report, because physicians, again, are receiving all kinds of information, all kinds of reports in really every direction. So this is our standing guide, that this is what we are doing, but the goal here is to really capture that missed code for the year and really drop it in claims, because that is the big goal. They need to get that captured so that CMS can allocate appropriate funds for the care of these really sick patients. Okay, do we have a next slide? Okay, yes, wonderful.
It's just going a little slow, I'm sorry.
No worries, Emily. So yes, I mean, that's our story, but also to really highlight Houston Methodist Coordinated Care strategies in driving physician and practice level engagement. Not only we empower and educate at all levels, but we really celebrate the work of our clinicians and support staff across the board. So here's an example of a recognition that we roll out every year, and we call it the Honor Roll Recognition Program. And we strategically design the Honor Roll KPIs, for the first 9 months of the year, having every physician and really every physician who's going to focus on these KPIs individually then drives collective goals for that practice. So this is a practice level recognition. So really, as we are reporting out their performance under the KPIs, risk adjustment is on the top of the list. It has the most points. This is so crucial and so important. And so we score them. We tell them, this is now, you have the tools, you have the resources, here are the reports. And so we really empower them to achieve the highest points. And then quality performance, of course, we're very quality driven. But again, as you could see, this is a strategy that we're utilizing from like, we rolled this out in, we rolled it out in July. So as you could see, the time frame was through July, and then we said, okay, it's going to end at the end of September. But we're looking at their year-to-date performance till September, and then we score them. As you look at the MSSP patient scene, really drawing your attention to how there was an example that Hema shared earlier where ACOs are really, there's missed opportunities in capturing the patient's conditions. But again, our ACO's goal is that we want every single patient seen by their primary care physician. Hence, we bring out the list of patients that are not seen every single month. And then we give them a goal and say, okay, if you see 90% of your MSSP patients by, like for instance, honor roll by 9:30, these are the points you will get. But again, that is also tied into the fact is that we're really driven providing that patient-centered quality care. We want our patients to be seen, and we want to be proactive in capturing their conditions and keeping them on a good track. And so again, hopefully this example was helpful and our story was helpful. We still have our work cut out with few weeks remaining, but we're really optimistic that with the collaboration of HDAI, their wonderful platform and the report and the curated reports that we brought to our physicians. By the way, our physicians were very fond of these reports, this is a great segue because then they said for our Epic practices, of course, they want everything integrated. They want it to be built into the chart. And those are some of the things, our next steps that Emily's going to speak through.
Yes, thank you, Wajiha. It's so fun to hear about, especially the end part, the celebrating. And I think we've honestly, it's been a lot of work, but it's been a lot of fun partnering on this together. It's been such an iterative process, and to land on something that we know the physicians are finding helpful and enabling them has been amazing. And so to your point, to move away from that paper state and that process of really just manually sending these files back and forth and streamlining workflows to make clinicians' lives even easier will be a huge goal for 2026. And we've really already started that planning. And we think about this with a bidirectional integration or a write back with the AHR so that we can actually populate best practice alerts of our own with those really unique catered HCC focus areas. And then I know that we've talked about one of just HMCC's main goals is going to be just aligning on that one approach across the whole organization when reporting gaps in HCC opportunity. And we're genuinely just thrilled to continue the partnership and to figure out what we will tackle next and even earlier. And I have no doubt we're going to continue to see HMCC's trend work towards the first percentile, which was good as a reminder. Okay, thank you. That was a lot of content. Garrett, I believe I can pass to you for what questions we can answer. I know we're a little tight on time, but.
All right, well, welcome to those of you who are just joining us, and thank you all. This has been a fantastic presentation, and obviously there's a lot to cover. We have a big audience, a lot of questions to come in. We did get a chance to answer a lot of your questions kind of in the stream as they did come in, but we have a few here that I wanted to, in the time that we do have, to ask. This first one is this. And let's go back, I guess, which you have, I think, to what you were talking about. Did you prioritize based on patients who are coming in, or did you try to get the patients to come in? I'm not sure that if that is, if you understand what they're referring to?
Garrett, I actually can't hear you well. You were cutting off. Can you repeat that question?
Oh, my apologies. But the question is this, did you prioritize based on patients who are coming in, or did you try to get the patients to come in?
Great. That's such a wonderful question. So initially, we actually prioritized based on, just looking at the gaps. What are the HCC gaps by patients? But as we progressed into month 3, we started receiving feedback from the physicians, giving us, asking us that can we get the same data aligned with the patients that are already scheduled, because that is kind of like the low-hanging fruit. We want to ensure that every patient that's already scheduled, that we capture those conditions and it's not missed. And that way, then they can go back and if patients are not scheduled and they have a number of HCC conditions not captured, then they can actually do a televisit or another visit with them to get that captured. But they certainly did not want it to miss with patients already scheduled between now and end of the year, and ensuring that that's going to be 100% captured.
Great. And the next question here is, and I apologize for any background noise as I am at a conference right now. Did HMCC rebase in 2025 or 2026?
In 2025.
2025. Okay. All right. Next question here is, you mentioned that you prioritize high-risk patients. What is your logic of categorizing a patient as high risk, or medium risk, or low risk?
Great. So because we are getting that data from HDAI, we're actually following their predictive analytics and their modeling to give us that information. And Hima can probably speak through that.
Sure. Thank you, Wajiha. So if you think about the weighted gap that we provide Wajiha with, so weighted gap is our conversion of the raw RAF for HCC that you get from CMS. It is treated by the likelihood of that HCC is going to be captured this year and the patient's history, the clinical relevance of that particular HCC. Could you, Emily, go back to slide 12 quickly?
It wasn't moving very fast, so I'll try. Okay. Can you see this?
Yes. Yeah, great. This is great. So quickly give you this example just because we have a couple of minutes. So if you look at heart failure and chronic ulcer of skin, heart failure's CMS gap is 0.36. So that's the raw gap, which is listed under gap. And chronic ulcer of skin is 0.87. We convert these numbers and we say instead of 0.36, the weight we assign or the risk is 0.17 for heart failure, and for chronic ulcer of skin is 0.13. So we are basically multiplying the RAF opportunity by the year-to-date expected recapture rate, as I talked about. So this is a likelihood of that particular condition being captured at this point in the year by a typical ACO in the nation. So this is based on our predictive analytics. So essentially, the risk is based on where the recapture rate is at this point in the year and also the actual weight. So it's a combination of those two. Thank you for the question, Ma'am.
Thank you for clearing that up, Emma. Unfortunately, we are out of time. That hour went by very fast. And by the way, if we didn't get to your question, or if you have a question that you would like to ask, still go ahead and use your control module and drop that question, and someone will reach out via email afterwards to make sure your question gets answered. But as we close out, first of all, I want to thank you, Hema, Emily, Wajiha, for a fantastic presentation. It's very thorough. And I wanted to encourage you to head over to vbcexhibithall.com and check out the HDAI virtual exhibit booth here. In the slides, there's going to be a direct link to where you can get there, but you're looking at it here. You can just go to vbcexhibithall.com and find it there. But there's going to be a lot of great resources and information if you want to read up on what they're doing and kind of educate yourself on their offerings, etc. You can feel free to do so. And again, there'll be a link there, as will also be where this webinar is archived in that library there. You'll be able to find it. And then finally, if you would like to reach out directly to the HDAI team, I'll have you go to that. Oh, actually, one other thing real quickly is they do have live demonstrations available upon request. So feel free to do that. If you would like to reach out to the team directly, this very last slide here, and again, you can download it when you go to the link that we're going to send you afterwards at info@HDAIinstitute.com, or feel free to reach out to me. I'm happy to facilitate an introduction for you if that's easier. Thank you all so much for joining us. We hope that you will join us again on the next one. Have a wonderful rest of your week. Bye-bye.
Thank you.
Thank you.